So let's just look at the informed consent process. And I'm going to first just look at the informed consent that we do with both the masculinizing and the feminizing treatment, because there's actually some things that are the same. And then we'll look at the two treatments in specifics. So just a couple of myth-busting things. Very important, you don't have to be on hormones to be transgender. So not all transgender people take hormones, and being on hormones doesn't suddenly now validate you as being transgender. Some transgender people simply use social transition, for example. There's no rules in terms of how long you should have been through social transition, exactly what kind of, how quickly you need to go through your hormone changes. It's very much dependent on your patient. The word gender dysphoria specifically talks about this extraordinary feeling of discomfort in their bodies that is not aligned with their gender identity. And some transgender people can be extremely dysphoric. So they really struggle with their bodies. And some transgender people, it has no effect on their emotional side at all. The level of dysphoria is not a prerequisite for gender-affirming hormone therapy. Gender-affirming hormone therapy is what helps people thrive. And so therefore, they don't have to have dysphoria to be able to go on hormones. As we've said, gender-affirming, being transgender is not a mental illness, so you don't need psychotherapy or a psychotherapist or a psychoanalyst to be able to go onto gender hormones. We talked about that last time as well, is that although it's not a mental illness and we don't need our psychologists from treating being transgender, it's quite rough in the world of today to be transgender, and there's a lot of boundaries we have to negotiate, and therefore having mental health support is sometimes very necessary. And it's not necessary to have real life experience or to have gone through social transition before you start hormones. So for example, you might have somebody at school who's always presented as a boy. Now they're going to go to university. They want to start at university as their gender identities, make sort of a fresh start, use the she, her pronouns, use their name that they've chosen, and then they might very well start on hormone therapy at the same time. So there's very much tailored towards your patient. And our transition goals, we can't also decide what we think their idea of masculine and feminine looks like, and therefore we need to be very clear about what it is that they are wishing for before we start the journey. So what's the indications for gender-affirming healthcare? And it's very simple. It's a desire to use gender-affirming hormone therapy. So it's exactly like contraception. Patient comes to you, they've looked at their life. This is something that will add benefit to my life. And of course, it has to be related to the fact that they have this incongruence between the gender they were assigned at birth and their own experienced gender identity. And of course, they have to be able to make an informed decision and give consent to treatment. So they have to be able to understand what they're letting themselves in for. We've talked about the mental health, and we do quite often see people who are coming in with quite bad gender dysphoria, struggling with depression, struggling with anxiety, just because it's been really rough managing all of these different dynamics in the world around them. And we don't first have to try and treat their depression before we start them on hormones. As a matter of fact, often the gender-affirming treatment in itself already makes a huge difference to their mental health. But you certainly want to make sure that you manage both, so one can treat those concurrently quite happily. You do want to do a good psychosocial assessment, but that can be done by whoever is starting the treatment. So myself as a family physician or an experienced GP who's prescribing this treatment is part of what we call in family medicine our biopsychosocial contextual approach. And we need to understand this is not just about the changes they're going to go through as an individual, but that changes is going to also affect the world they live in. And they need to start being able so you need to understand how much support is there at home, what's going on at work, what's going on at school, et cetera, et cetera. So some important discussion points that you're going to have with your patient is firstly, ask them what are they expecting for. So they've read some stuff on the internet, and sometimes, yeah, you can help already correct if some of those expectations are a little bit unrealistic. We want to tell them what changes they're going to see and how long it's going to take, and it takes much longer than one think. And well, interestingly enough, most of the changes are reversible. So although we get all excited about hormone therapy, the reality is, unfortunately, when you stop the treatment, most of those changes are just going to reverse back. and this needs to be described and explained. There's obviously side effects to the medicines, like there is of anything that one takes, and it needs to be monitored. We need to talk about them, about complications, also very uncommon, but they have to know when to come in. And probably the most and the biggest and difficult conversation is around reproductive side. So fertility is the big issue and is the one that has to get the most time spent on, especially the younger they are, because very likely the hormone therapy is going to impact on fertility. And the longer you are on hormones, the more your fertility will, well, already early on, you will become less and less fertile, and eventually you will be permanently infertile. This does take time. And it's not something that happens quickly. So you also can't say, oh, now that you're on hormones, you also don't have to use contraception. So one has to be careful with that as well. But this needs a conversation. And this is a little bit similar with gay couples or lesbian couples, where one's already saying you might not be able to have your own genetic children, but you could potentially consider things like adoption in the future, and really to have had those conversations. And quite often they have to have those conversations with families and parents as well. There needs to be enough opportunity for them to ask their own questions. They read all kinds of stuff on Google, and very important, document. So we talked last time a bit about our non-binary folk. These are people who don't quite fit in the boxes. You know, they don't feel male or female. And a lot of non-binary people find it very frustrated to be put into a gender box. So what quite often happens is those that were assigned female at birth might want to take a little bit of testosterone, grow a little bit of a beard, and just to make them sort of a little bit more androgynous or a little bit more confusing their gender. And some of your gender, some of your trans women might just want to take a little bit of estrogen, those who were assigned male at birth want to take a little bit of estrogen to maybe make them a little bit more feminine. And so you end up having somebody where when people go, I'm not sure what gender they are, then they feel that works for them. They don't get put in a box. And so very important is to really discuss with the patient. So what we often do is we use sort of much lower dosages than we would use for our transgender patients. So this is I'm going to be drawing on the Gender Affirming Healthcare Guidelines from the HIV Clinician Society. It has got two appendixes where they actually have a whole lovely one on masculinizing treatment and one on feminizing treatment. The first bit is exactly the same, so I'm going to go through that quickly with you. And these are the things you can literally copy out of the guideline. I've actually adapted them slightly for my practice, and I will make those available as well. So when I start with a patient, so usually they've come in, they've said they're interested in hormones, we've done all our history, etc. I will always explain to them this informed consent model. You are in charge. You are going to sign consent for this. Please note that all the information on the internet is not necessarily correct. So we need to make sure that you understand exactly what we're going to do. And very important to realize that every client is unique. So it's like puberty. We all go through puberty differently. So you can't go and look and say, oh, my friend's on hormones and that's what's happened to them. It doesn't give you any reference on what's actually going to happen to you. So then we just emphasize what we've said earlier. You don't need to see a psychologist to be able to start on this treatment, but you do need a good support structure, and one would explore a little bit what that might be. And they don't need a fancy specialist to prescribe the hormones. This can easily be done by a general practitioner, medical officer, family physician. And then we also tell them about the team. So they're cool people like speech therapists that can help you with voice, occupational therapists that can help you with gender expression. And there are also surgeons in the private sector if they wanted to explore gender affirming surgery. So I was going to talk a little bit about the law and how Home Affairs works. So you're allowed to update and change your gender marker under our law, but you need, heaven knows why, 2 letters from healthcare professionals that says you've undergone medical or surgical gender affirmation treatment. And as soon as they're on hormones, they're undergoing gender affirmation treatment. So usually this is something just where 2 people in your department, I've got myself and another doctor, we will always do the 2 letters. Unfortunately, at the moment, there's no non-binary option, but that is being discussed. Remember now in our IDs, your ID can tell you whether you're male or female, so they're going to have to rethink IDs if they want to put in a non-binary option. If you want to change your name, you don't need letters from the healthcare workers. You only need it for your gender markers. And it's a little bit useful for them to start thinking ahead because the whole home affairs process takes an extraordinary amount of time. And it's usually a whole back and forth, and it depends on how clued up your particular home affairs are. And they need to start thinking ahead in terms of if they change their name and gender marker, the impact in terms of their registration as a student, if they're busy writing matric, if their banking account, and just sort of help them with some of the practical things to think ahead of. Some of the other things to consider is that going onto hormones is going through puberty. And so there's different ways in how it might exist. And again, just like we all go through puberty differently, but people might become a bit more moody or tearful or irritable or even shut down, especially in the beginning, and it all settles down. Very important, this can impact definitely on relationships with family and significant others. So unfortunately, it's not something you can decide, okay, what am I going to hide from granny, for example. So if they're going to go through transition, there needs to be discussion in terms of how does your immediate family feel about it? Where's the extended family at? Who are your best friends? How do they feel in your school? And I'm going to talk, I've got a whole little bit that I'm going to do just before the tea break as well, where we're going to particularly talk about sexual intimacy and desire and things like that. Unfortunately, being transgender is not always safe. So there needs to be a little bit of a discussion around that in terms of safety, especially within their work or school places. So is your school affirming, for example, of transgender people? Can you use the uniform that you want to use, for example? At your workplace, does your boss know? How would your colleagues potentially respond? So these are all things to think about. When we go through changes, we also have to let go from some things. So it's also good to talk about the fact that actually some of the changes might be awesome and some might not be so awesome. And there's all kinds of odd things. The body changes. So you might have taste changes or body odor changes. Your appetite and your sleep might change. So you're going through this puberty, right? Going through this transformation process. So in terms of monitoring and follow-up, so patients need to understand that we monitor them, and in the beginning a little bit more frequent, but eventually they're going to be on 6 monthly follow-ups and get a script every 6 months, and they'll only need annual blood tests. So we actually slightly overkill in comparison with contraception, where we don't do any bloods, for example, but we're on a little bit on the careful side. So the typical things we want to monitor in feminizing treatment is we monitor their kidneys and their potassium. We'll talk about that. And then we monitor the liver in both feminizing and masculinizing treatment. And then in masculinizing treatment, we have this interesting thing that you can get a polycythemia, your hemoglobin can go up. So I always explain to patients, all that means is you might end up having to donate bloods. And then hormone levels you don't need to do hormone levels, but from a safety point of view, as a healthcare provider, I really like to have hormone levels. And we can do them on the public sector. And you just monitor an estradiol level in trans women and testosterone in trans men. And once they're on target, so they've got the same levels as a cisgendered man or a cisgendered woman will have, then you don't need to monitor the hormones again. So let's just look at masculinizing treatment quickly and what that entails. And here we want to promote specifically virilization, and we don't use any oral testosterone in any setting. We're suspect of guys trying to sell you oral testosterone. And the preparation that we have, and it's the same one that we actually use in the private sector, so it's a great option, is a testosterone cypionate. It comes in 100 milligrams per milliliter, and it comes in a 10 ml vial, and they're going to give this as a weekly subcutaneous injection. So exactly the same way that you're injecting for diabetes. So it's very easy. You can do it yourself at home. And usually, they usually really like, all my trans patients love being able to give them their own hormone shots on a weekly basis. Usually the periods go away if you're on testosterone, but there are some who do have persistent bleeding. And sometimes some of them go, no, actually, I just want to sort the bleeding out. I don't want to go quite on testosterone yet. And then we can add something like Macrovil or the mini pill. There is options to help to get rid of the periods. And then there's topical minoxidil, like the guys use for balding, that can be used if one wants that beard to come in a bit quicker. So this is the slide, the table everybody's always interested in. It's from the HIV Clinician Society guidelines. And I want you to notice the things that are actually irreversible. So the first is the deepening of the voice. So that's, and you can see it takes a good 6 to 12 months before the voice will break and might drop half or a full octave. And it takes about 1 to 2 years to get a deeper voice. And then the big thing that the trans guys really want is the beard. So once you start growing a beard, that's a sort of an excellent way to start being able to be identified as male. And you can see again here, it takes 6 to 12 months before the beard really starts to come in. And it can take a good 4 to 5 years before you have a full beard. If in your family you have male, sort of the higher male scalp line, the scalp hair loss that we see with some men who bald a little bit or just have a higher scalp line, that can also happen within the first 6 to 12 months. But that very much depends on the genetics in your particular family. All the other changes are reversible. So you're going to get a bit of acne. Thank goodness that does settle down. But they get increased muscle strength, and you don't get muscles unless you gym. So you have to gym with your testosterone. The fat distribution means more of a straighter body. We mentioned the period stops within usually 2 to 3 months. It stops quite quickly. And then vaginal, they can get a bit of clitoral hypertrophy. So some of the trans men, oh, sorry, apologies. There's just something that's gone funny on I'm just sorting it out. I'm hoping you're still with me. Pear, am I still with you guys?
Yes, I can still
Okay, great. No,
see
sorry, my screen
you.
has just vanished on me for a second. Am I back? I'm back. Apologies for that. So clitoral hypertrophy. So in some men, you can get the clitoris starts to grow, and some men it can grow like a good 1 or 2 centimeters. Some trans guys have read about this internet, and that sometimes becomes an expectation. So that's one of those things where you've got to manage the expectations. So just to warn them, that can sometimes happen. It doesn't mean you have more sexual pleasure than somebody with a smaller clitoris. It's still the same amount of nerve endings, but the area is just bigger. But it's not something that you can predict beforehand. So it's not something also where the more testosterone you take, the more of that you will have. Vaginal atrophy is sometimes problematic. That's usually only after many, many years on testosterone, and we can treat that with a local cream. So it's very important to explain to our trans guys that unfortunately testosterone is not going to take the breasts away, and it's not going to make them grow taller. And then the main risk, interestingly enough, is this increased red blood cell count, which you treat with donating blood. That's probably the one I've seen occasionally. And then cardiovascular risk, to realize that so cisgendered women has got a lower risk. Estrogen is protective against cardiovascular disease until they've gone through menopause. So when you start taking testosterone, your trans guys end up having the same risk as men their own age, as cisgendered men their own age. So we haven't actually increased their risk over and above the normal male population. But just like anybody, we would always explain to them that, of course, that risk will be more increased if they smoke, if they use alcohol, if they've got diabetes or high blood pressure. So all my trans people always tell them you can't pick up smoking if you like to stay on your hormones. Liver complications is a possibility with any hormonal treatment, very rare. I have not yet seen that in my practice. And of course, if somebody's extremely anxious or very psychotic, the testosterone can make you more irritable. So that might be something just to think about if you have somebody, but they have to be quite severely mentally struggling. Some of the side effects, again, think teenage boys. Not all teenage boys necessarily becomes automatically aggressive, but it can make you certainly a little bit more irritable, have more mood swings. Acne is very irritating. And then, yes, if in your family you do have that sort of receding hairline, that's the word I was looking for, not a scalp line, a hairline. If you've got a receding hairline, might be one of the effects. Our contraindications, you have to do a pregnancy test. You can't get hormones if you're pregnant. We have to check for active, if they've got a cancer that is obviously sensitive to testosterone, then you can't use it for that. And any untreated polycythemias. Also, they would have to donate blood before you can start. So fertility we've talked about, and you can in private have the option, if you're a trans guy, to, for example, have your eggs frozen. but that's going to be expensive. And so it's one of those conversations that needs to have. The biggest expense is keeping those eggs frozen over time. So let's just look at our feminizing treatment quickly. So for estradiol, which is what we use for our women, in private, they usually use the injectables, exactly like the testosterone. It's a weekly subcutaneous injection, works very nicely. We don't have that available in the public sector, so we use the oral estrofem, which works very well. But because estrofem is digested through the liver, it just doesn't suppress the testosterone to the same extent. And because of that, we therefore combine it with spironolactone, which has a side effect of suppressing testosterone. So actually, people who are on high dose of spironolactone can get gynecomastia, you guys. So we actually use it for that reason. So again, the same table for our trans women in terms of what they can expect. And you can see here our only non-reversible is our breast growth. And again, it takes 3 to 6 months before the breast buds start and the breasts start to grow. It takes 4 years before you have a breast size. And your breast size is determined by your genetics, not by the amount of estrogen that you're on. But very notice your body fat distribution, your decreased muscle mass and strength, the skin softening. We're going to talk about sexual desire just now. Your decreased terminal hair growth. All of these things are reversible changes. You stop the treatment, it's all going to go back to the way it was. One of the biggest challenges for our trans women is the voice. So unfortunately, testosterone changes the voice box completely. And so they might have this, if they have a very natural, deep voice, this is hugely problematic because they might have gone through full transition. It's absolutely, but on the phone, they get misgendered. And they're terrified in a service delivery setting if they have to go and order to take out or if they've got to order a drink at a bar, that as soon as they open their mouths, the voice is much deeper than is expected. And sort of that quite often might out them. So this is one of those things where speech therapists can sometimes help. So limitations, it doesn't take the beard away completely, but it does thin out hair when it becomes less hairy. I've mentioned the pitch of the voice, and it's obviously not going to take away things like the Adam's apple, which is a permanent structural thing. So the big thing in terms of risks, anybody on estrogen, we always worry about deep vein thrombosis, clots in the legs or clots in the lungs. And this is the same as people on contraception. There's obviously a higher risk once we get older, once you smoke, if you've got pre-existing medical conditions. So also for our young people, we really get them, no, never, ever smoke if you want to keep on your hormones. And you also, there's also risks of things like gallstones and gallbladder, very uncommon, but we do keep an eye on those. And then very uncommon as well, not something that I've seen yet, but there's a possibility that one could get a little benign growth of the pituitary gland in the brain, and it can press on the optic nerve and give visual disturbances. So you mention it to patients if they do get a visual disturbance to please come in. Just the contraindications would get tricky is if they've had a deep vein thrombosis in the past or they're at high risk of a DVT for some reason. If they develop an estrogen-related cancer, so very important, estrogen, just like contraception, doesn't cause cancer. But obviously, if you've got an estrogen-sensitive cancer, you can't be on estrogen. And if you've got advanced chronic liver disease. The side effects, again, puberty. So, and it's got like contraception, a little bit of headache, the mood changes one would see in puberty, and we'll talk about sex in a minute. So fertility here for our trans ladies, sperm is a little bit easier to freeze and might be cheaper to keep at a cryobank, so also important just to have this conversation. These are the consent forms. They're also in our guidelines. So we have a form that the patients actually sign and gets kept in the folder. So just in summary, in terms of informed consent, please make sure your patients has actually understood what you've told them. This is not a gatekeeping or judgment space. It's all about the patient making all the decisions. We review and reaffirm consent regularly. Every single time we meet them, we go, you're still happy, we're still on track. And it's all about a comprehensive care package that we are trying to create. Thank you very much. That's just
Madeleine, there is a question for you in the chat.
Excellently. Thank you, Pierre. Okay, great. So thank you. So In this second session, so at the moment I'm sort of doing so that all of you that sees people who are transgender know all the processes they're going through. The session we're going to do after the tea break, we're going to go